Our first speaker is Amie Shao. Amie is a principal with the Mass Design Group, and she'll be speaking about redesigning hospital spaces on the fly to protect healthcare workers. Amie?
Hi, thanks so much for having me here today. So Mass Design Group is a nonprofit architecture research firm based in Boston, Massachusetts, and Kigali, Rwanda, where I'm calling from right now. Over the past decade, we've taken on a range of work across geographies to promote health and equity. So while on the one hand, we've done projects like the design of the National Memorial for Peace and Justice in Montgomery, Alabama for Equal Justice Initiative, which is just addressing healing on a societal level. We've also spent the last 10 years partnering with global organizations working on the front lines of global epidemics, from responding to Ebola in Liberia and cholera in Haiti. So what I wanted to present today was a case study which in late March was initiated by two doctors at Mount Sinai Hospital at the epicenter of the New York City pandemic at that moment, John Bukovalos and Michael Dollinger, who reached out to us to see if there are ways that the physical environment of COVID-19 care units could be tweaked to lower infection risk to healthcare workers. And then we in turn pulled in our colleagues at Ariadne Labs to bring a systems thinking angle. Next slide. We recognize that there were a lot of hospitals implementing spatial redesigns on the fly to prepare for the COVID-19 surge. And what we wanted to do was capture quick interventions that were working and also share lessons to assist other facilities. And the first thing that we realized was that any research and collaboration would have to be very nimble in order to be helpful. So over the course of 3 weeks, we ran a rapid response spatial research methodology, which was adapted from methods that we'd previously developed with Ariadne on a study that linked L&D unit design to C-section rates. So using GoPros and Zooms, but also analog stuff like paper and crayons, the clinicians were our eyes and ears on the ground and helped us peer in really well to active COVID care units, annotate floor plans, and extract lessons to share. Next slide. So this next one will show you some visuals that help to convey the spatial modifications that Mount Sinai had made. Starting in mid-March, they converted 260 normal patient rooms to specialized COVID care rooms suitable for airborne isolation. And across 3 units that we looked at, which were an adult ICU, med-surg unit, and then a unit in the children's hospital, what we saw was that a lot of critical care was taking place beyond the patient room. To minimize clinician exposure, we saw that corridors had become these do-everything spaces, and there were IV poles, patient monitors, PPE carts, trash cans, workstations. It was doing it all. And we realized really quickly that enforcing proper infection control protocols in corridors and these key thresholds like unit entrances was just as important as in the patient rooms. Next slide. So when we were zooming around and doing all of this together, which was really fascinating to do from my kitchen in Rwanda, we saw a lot of design hacks which were tremendously innovative, but also revealed implementation gaps and created some confusing variability between units, like things like signage, the way that individual face shields were being stored. We also saw differences in personal perception of risk zones within care units. So in this picture here on the left, one of the things we did was ask clinicians to create risk heat maps, and we had them color code floor plans with red for hot areas, green for clean areas, and orange for warm. And as you can see here, 3 clinicians drew totally different heat maps of the same space. So what we concluded from that initial study was the notion that spatial literacy, how you read and perceive space, has a really important implication on the interpretation of safety protocols. And then in the end, visual cues, even things as simple as paint or tape on the floor, can be a really powerful tool to orient people in a care environment that's otherwise really unfamiliar and constantly changing and high stress. So I think we're really excited that there's huge potential for researchers, designers, care professionals to collaborate to develop greater spatial literacy and implement strategic design interventions.
Amie, thank you so much. That was really fantastic and very, very intriguing. And just to think about how we understand the relationship between the design of a unit and even an individual's spatial perspective and how the impact it would have on transmission and their own protection As you think about where this will go, at Ariadne, we often think about scale. How do you think about the scalability of this project?
Yeah, so what I spoke to today was a 3-week case study, as I mentioned, on one large urban hospital in the midst of the surge, which looked at ways to minimize infection control for clinicians and dedicated COVID care units. So our team is now trying to get to the middle of the Ariadne arc, and we're working to put together a learning collaborative of multiple health systems. We want to look at a broad range of facility types in a broad range of geographic contexts and in different moments of that wax and wane of the pandemic. We want to also look at a broader set of care delivery spaces, not just dedicated COVID care units, a larger definition of safety beyond infection control, also things like communication and morale and stress management, and all health workers, not just clinicians. So ultimately, we're really hoping to develop some clear spatial guidance that could be used globally by health systems to transform their infrastructure in this COVID era. And we feel like a new awareness of how space can help or hurt is going to be a good jumping off point to creating a healthier built environment moving forward.
Thank you so much, Amie.